Okay, well, welcome to our first post-clinical conference. This is completely a casual meeting, and it's really for you guys to, for maybe me to clarify a few things, questions that you might have about your clinical component, and for you guys to share with me and with your classmates about how it's been going and what you've been finding. So, one thing that I wanted to show you, I don't know, have you guys ever heard of Robert's Rules? So Robert's Rules are the rules by which a meeting takes place. And so when you go into any of your meetings with your supervisors or your any kind of, administrators or something, they might have an agenda that looks something like this. And it usually looks the same with the attendance on the top. You have your old items, your new business, and then other action items on there. So this all really comes from something called Robert's Rules. And if you click on the hyperlink there on Robert's Rules in our agenda, it takes you to the rules of order. So it used to be, I think this probably came from the British Parliament when everybody was yelling and screaming different things. They came up with these rules about, okay, this is how we're going to conduct a meeting. So this is why you'll say, you'll hear people say like, I'd like to make a motion. And do I hear a first? Do I hear a second? Let everybody vote. Have you heard that when you've been at meetings? So these are all about Robert's Rules. And I think they're really important for healthcare administration leadership students to know, because this is when you guys are leaders and you're conducting meetings, this would be the standard that you would go by. So I have that link for you. It's not the way we're really going to operate this meeting, but you will notice when you're going with your preceptor to different meetings that they might, have operate in this certain way. So take a look at those rules and let me know if you do kind of see that when you're in these meetings with the C-suite and everybody up there. The next thing I wanted to talk about was the definition. So, when we were talking about transitional care, care management, care coordination, case management, I was like, I don't even really know what the difference is between all of these. So you guys really helped in the discussion. And if you click on the definitions, it takes us to that sheet, that Google Doc we've all been working on. And so I kind of put the definitions in there. This came from you guys. So I thought maybe so case management we know is episodic, right? So that's not what we're talking about when we talk about care coordination. But I put some definitions in here, and I think we talk about like disease management, and that's a single disease, right? And then there's like diabetes, standards of care for diabetes. And these are the guidelines that we use for this population. But then I was looking at, I had a conversation with Erica about, am I talking too fast? I haven't had any caffeine for 5 days, but I'm still going. So we had a conversation. She's like, well, I really don't have a population. I was like, yeah, you're right. And then I looked at some of the definitions and see if we read within these definitions. It really said that care coordination, let's see, so it's the deliberate organization of patient care activities between two or more participants, including the patient, involved in patient's care to facilitate the appropriate delivery of healthcare services. So that's really separate from having one disease, right? So this is really, care coordination takes place for a person with whatever's going on with that person. It's not like I'm just going to coordinate your diabetes and ignore all that other stuff. Care coordination is holistic. And I was wondering if you guys might agree with my, what I was thinking here is like what's the difference between care management and care coordination? Anybody want to shout out anything? you think they're the same thing, or you think they're different?
I think they're a little different. I mean, I think coordination is pulling a whole bunch of people, but you still have to have somebody who's kind of the overall kind of leader or manager of that. So I think that they're similar, but I still think that the coordination part takes a whole lot of different people, and then the management part might be just like one head person.
I looked at, so the definitions, I think, so transitions we had was, you're transitioning, and it's not always from hospital to home. It can be within a unit. It can be anywhere a patient's going. And then transitional care, it says, is a broad range of services and environments with the ultimate goal of safe and timely passage of patients between the levels of healthcare and across care settings. So I thought maybe transitional care would be, the bucket, and or transitional care would be like the heading, and then the subheading under that would be care coordination. So care coordination is a way that we organize these transitions. So when I talked about, ask you guys to do the elements of care management and the elements, the models of care management, why don't I can share my screen here. Really what I got back from you was information about transitions. And so I was like, I don't know if that's right or not, but so that's why I really looked at all of this a little bit deeper, because I haven't been able to find a great textbook. Let me pull my screen over there. So can you see this now? This care management, this is the document we all been working on. I've been really looking for a textbook to guide us through this. And my philosophy is always, I don't want to burden you guys with spending any more money on textbooks than you have to. And there's so much information out there. The Agency for Healthcare Research and Quality is phenomenal. We have that, the Improving Chronic Illness Conditions is one of the resources I gave you. It has tons of stuff about care management in there. So I kind of took from you and also looked at the different resources and tried to make these definitions. But I think if we're talking about, population health and disease management is the bigger bucket, and then care coordination might come under that, and then transitional care maybe is a part of, so you have that right there, as a part of care coordination. And I was wondering if care coordination might be the verb, like I'm going to go out and coordinate your care, and then maybe care management is the noun. Like today or care management is the goal of hospitals to improve the triple aim. So do you think that might be along the lines there? So I think as we're going and we're all reading about this, maybe we can, be thinking about these definitions, and any time that, this can be a document that we're using throughout the class to update these and clarify. But I think we all understand that transitions are messy things, and it takes a lot of people and a lot of elements to make sure that they happen correctly. And I'm not sure, but I don't think they happen correctly most of the time. I wonder, I haven't seen any statistics about that. Like how often does a person with multiple chronic illnesses go home from the hospital with everything being taken care of? I would say that is a very slim. So anyways, we'll jump back. So here we had our care management, case management was episodic. Well, care management is something continuous. So like primary care, medical home, those are something that the patient is assigned to a doctor, and that doctor stays with the patient. So that's really, I think, what this class is about, is talking about how we do that. And then we have links here to our components, the team members, models, team members, and the models. So this can really be a living document. We can go back and forth and update, and then update each of these individual documents. So any questions about that?
I just have, okay, so if I'm understanding this correctly, what my thought process on it was for like the transitional care, I think we all understand that it's transitioning from one place to another. It's kind of like the overall picture of everything. And then the care coordination versus the care management. My thought on that was like care coordination would be something like, as a bedside nurse, like coordinating with PT or OT at the bedside to make sure the care is managed for, you know, feeding or, you know, activities of daily living and things like that. And then care management is like the overall management of the patient itself to make sure things aren't, I guess, done twice, or just make sure that everything's smooth during that stay. Would that be correct?
Well, let's look at that, because, you know, if we're talking about an acute bedside nurse who's caring for a patient, that's really patient care, right? That's part of your job, and that's episodic.
Mm-hmm.
So I'm not sure really that would qualify as care coordination. I mean, that we're talking about here.
Okay.
That is more what I think what a case manager does, right? They take one visit, and then they are planning for, you know, what's going to happen after discharge. Mm-hmm. But they don't follow the person afterwards. They really say, okay, now you go to your primary care doctor, you go to your medical home, and that person can follow you over time.
Okay.
So, you know, if this is something that we are looking at, and we see that, you know, that's not right, then we can fix that. But from what I've been reading, when they're talking about care coordination, is more with primary care and medical home models.
Gotcha.
Now, when we're talking about transitional care, right, that is probably a part of care coordination. And so when somebody is transitioning or being discharged from the hospital, that's a part of care coordination.
Okay.
Right?
Okay.
So when you are at the bedside there and you're getting a person, you know, ready to go to the ER, you're getting them ready to go to a skilled nursing facility, that is that transitional care.
Okay.
I think it's confusing. I don't know. But we had care coordination was the deliberate organization of patient care activities between two or more participants involved in patient's care to facilitate the appropriate delivery of healthcare services. So that doesn't really say it has to be over time, right? So if you guys can help me, I think we can have some more discussions about this and talk about exactly what the difference is between care coordination and transitional care. Okay? So I think when in these components and the team members and the models, what we talked about in all of these were more transitional care, right? You guys did named all the transitional care models. Okay. So how I've gotten, I think, Erica, you were the only one I haven't gotten a log from. Maybe, have you given me a log yet? If you're, you have to unmute yourself if you're going to talk. I wonder if I can unmute you. I think I just unmuted you. Now we can't see there. Now we can hear you, but we can't see you.
Yeah, I accidentally turned my video off. I think I did share the lock with you because I got your reply back.
Okay. Maybe I was just looking at week 3, so you might have put one in for week 2.
You mean the Google Drive to share with you, right?
Mm-hmm.
Let me double check. I do believe I shared.
What I wanted to clarify about these logs are they're, first of all, obtaining signatures. So why don't we have mid practicum, and at the end, we'll get your preceptor signature on there. Sarah, I saw that you had gotten Dina's signature each week, but I think, it's okay if we do it halfway through. So at week 8 and week 16 or 15.
Okay. I was trying to set a time to meet with her, like before the end of the week, before she goes home, to show her. So that makes way more sense. Thanks.
Yeah, that should help. And then, so what you can count for hours and what you can't. So anything we're doing in the classroom should be didactic hours and not counted in the clinical. But this course is so closely linked between the two, it's really hard to do that. So if you click on that sample weekly hours, I kind of was thinking about, what might be included or what might not be included and what may be included. So this kind of goes through some examples of things that you might want to do and have questions. So, getting your preceptor agreement form, that wouldn't really be counted. That's part of the preparation for all of this. Any questions about that? What I have, I know I put this somewhere in the syllabus or the preceptor handbook, but damned if I can find it. I thought I said that I would you could do about 30% of your practicum hours can happen outside of the healthcare setting. So, when you're doing a SWOT analysis, you might be going through you might be sitting at home and looking at your hospital's org chart or something like that, or just looking at, what resources are available for people being discharged from the hospital. So there is about 30% where you can not be in the healthcare setting. So hopefully that'll make it a little bit easier to get your hours there. Any questions on that? But when you put your logs in, I'll go through your activities there, and if there's anything that looks like it's not time that should be counted, I'll just make a little notation there, okay? Or if you have a question, just ask. So these are resources for you, and you can keep this agenda, and just if you have any questions, go back in there. All these resources will be right within it. So by now I should have the preceptor agreement forms and all the learning contracts. Any questions about either of those? I think you guys have those all in. Sometimes you might need to find another preceptor, or you might want to go precept with somebody else because you think like, oh man, now I'm really interested in how the pharmacist manages medications. So I want to go spend some time and see how he's doing reconciliation of medications. If you want to do that, that's fine. That there's informal preceptors and formal preceptors. So it would be fine for you to go with that person. You wouldn't be able to don't do any patient care or anything like that with that other person. But like you can go to a meeting with another administrator or something like that. So if you have any questions about that, just check with me. And, if you're going to be spending any lengthy amount of time with another preceptor, then we just have them fill out a preceptor agreement form. And that's really easy to do. And you can spend, 4 weeks with them or whatever. Okay. All right. Now you guys are up. So we've got Sarah and Erica and Elizabeth here. And Sarah, where are you doing your, where's your healthcare setting?
So I'm spending time with our acute care director. I work at Sharp Chula Vista.
What's the name of the facility?
Sharp Chula Vista.
Sharp, right.
Yeah, it's the closest hospital to the border. So we get a complete diverse group of people, which is great. So I work in the ER, but for this particular project, I'm working on a reduction in readmission rates or reduction in length of stay, which came up just like probably yesterday. My preceptor was concerned that I was taking on too much, or she basically said that she was saving me from myself, that I had expanded my project to both heart failure patients, and I also found that our COPD patients have really kind of poor transitioning through the hospital and poor recognition. And so when I went to show all my information, she said, okay, slow down. I need to help you focus a little bit. And she said, you're not going to solve world peace. So let's find something for you to specifically work on rather than getting too broad, which I was super helpful, or I was thankful for. So,
so did you land on heart failure?
I believe I landed on heart. I started with them first, and I've had more time with them, and so I think I'll stick with them. I feel bad for the COPD group, but because they have the same exact problems, which is really quite interesting. And a lot of times, like I was saying in one of my writings, they're the same patient. They have, they have heart failure and they have COPD. So,
but you're gonna graduate from this program, and then you're gonna be administrator, and then you can get the COPD people. They're probably the lucky ones, because the heart failure are your guinea pigs.
That's a good point. So, it's very interesting. I've never known anything other than ER. So you're watching meetings and figuring out the process and how people actually transition through the hospital and how many people are involved is way more than I was aware of.
About how many patients do they see?
Well, it's
how many beds is it?
It's right now it's about 280, I believe, but we have a new tower which opens November, which will be an additional 200 beds. We've been under construction for, I want to say, 4 years now. And so what they're doing is they're looking at making an actual observation kind of transitional unit when the new tower opens. So a lot of this information on, recognizing patient deterioration and recognizing who is a heart failure patient hopefully should help for the new tower, and to see if these patients would do better going to an observational floor versus going to a full inpatient floor.
You guys have any questions or comments? Or do you guys have something like that where you work? No?
Somebody in our thread had something similar to a transitional kind of care unit. I was chatting with I can't remember who it was last week. And it sounds like that seems to be it sounds like it's successful. So I'll have to pick her brain some more.
It might be Chanel.
Yeah, I think that's who it was. Yeah, it was either Chanel or B, or maybe, I don't know. But so I'm just looking to help create a tool that recognizes these patients quicker. So what I sort of noticed so far is that we have nurse practitioners and we have different mid-level folks that help with the treatment and recognition of heart failure. But because our system is set up so strangely archaic, it takes 3 or 4 days to actually figure out where those patients are. So it's not set up for success right now. So by that time, 2 midnights have gone by and it's a full admission or it's a full readmission, and that's costly.
So what usually happens with heart failure patients? They have medication management that they need to be on. Do they have any kind of self-management education like they do with diabetes? Or like what is, when a doctor discharges a patient with heart failure, what are some of the things that they're going to tell them to do?
So it's kind of funny you mentioned that. So I went floor to floor, because right now there's no specific floor that takes these patients. They're just kind of dispersed through 5 different floors. And when I pulled their kind of discharge packet paperwork, they're all different. Like every floor has their own kind of take on heart failure, which I was kind of surprised by. I thought we were much more systematic. Everybody would have the same sort of education when they left. And so they talk about weight gain, they talk about diet and exercise. Some of them encourage a cardiology consult, but none of them are the same, which is strange.
Yeah, because a lot of EHRs will have like, you just push the button, right? This patient has these comorbid conditions, and then you push the button for discharge instructions, and so you get the same instructions every time. So that's kind of, that might be something, that you could work on. Even just that alone is getting, standardized discharge instructions.
They all have these packets, kind of like this, but none of them they're all the same looking packet, but when you actually open it up, the information that's in there is not the same floor to floor. So, if a patient comes back in, is readmitted and goes to a different floor, then they get different discharge instructions like every single time, which definitely is not going to help the patient long term. They're going to be confused. So it's an interesting project for sure.
Do you have somebody who's the head of patient education?
We have a brand new gal that's in charge of that. And so I think she's in the process of just kind of trying to figure out her role in the hospital. All of the floors have educators who educate the nurses, but there's not a whole lot of designated like patient educators. It's kind of left up to the bedside nurse. And when I chat with some of the nurses, you can tell some of them are very comfortable with heart failure and will talk my ear off about it and do a really thorough discharge. And those that are a little bit uncomfortable or less knowledgeable, they kind of avoid it. They don't, I think they don't want to seem like they don't know what they're talking about. So they gloss over the whole disease process.
That's Elizabeth or Erica, do you guys have anything like that in your floors with like patient education being different or?
For my clinical site, so that's what we're trying to figure out, me and my preceptor right now. So she's in charge of a lot of the education for the hospital in general. And I love the education portion of discharge and all of that because, once you teach somebody something, then they're able to teach themselves and teach somebody else. So I think that part's really great with the whole transitional care model. So with her, we're trying to figure it out because my hospital is such specialty, and obviously I worked in the NICU there, so I understand how the workflow is there. But even within the NICU, it's hard because it's not just like that example that I had thought of for the preemie population. It's not just premature infants that are in our NICU. These are infants that have congenital diseases that they'll never be able to recover from. Then there's also kids that I've sent home on hospice. There's kids that I've sent home on palliative care. Mm-hmm. So there's such a variety. And then each floor is like, one's NICU, one's PICU, one's a cancer floor, one's a respiratory floor where they have patients with trachs and TB and things like that. And then one's ortho where it's all post-op. So it's such a specialty based units that like finding something overall for transitional care models, I think would be kind of hard after like discussing things with her, for the whole hospital to create something. Although it sounds nice and pretty, each unit kind of would have to do their own thing. So right now I'm trying to figure out what would be the best place to go that would need, I guess, the most help in making sure that these patients are getting the education they need to move on to the next facility that they will be seeking their healthcare from, I guess, at this point, because they all go to different places. Like some come back to our clinic if they have like a G-tube and a trach. And so I think there's just so much that it's hard to narrow down which one I'm going to get into. And so last week I actually spoke with the spiritual care director, which is also very important, obviously going to APU and being holistic in our nursing care too. When these patients have end of life or they're in palliative care, who follows up with them? And so it doesn't seem like there's a follow-up as well. So I thought that was interesting because I've had kids that go home on palliative care or hospice, then they come back to our ED and you're like, we just discharged you a week ago and you're back in our unit again. So
yeah, I'm sure that's not where they want to be, right?
Yeah. So there's like a lot of, I don't know. So I feel like there's so many different things. And then education with nurses. I even was talking to my preceptor about, like, even just from admissions, we all kind of educate. You're supposed to get them ready from discharge from the point of admission. And even at admission, everyone educates their parents completely differently. So parents, I mean, for me, it's not patients, but parents are getting a complete different perspective for patient in bed A space to B space. So I don't know. I feel like there's so much that I'm just like, okay, I don't know where to focus. I think I'm right now exposing myself to realizing how much differences there are, which is nice, talking with like the different, like with her for the education portion, and then spiritual care, and then talking with the NICU and how many different things are in there. So I'm probably going to try to focus on the NICU because that's what I'm used to anyways. But I need to go talk to the care coordinators down there and see what kind of populations, and what their, I guess, standard discharge kind of is, so I can then pick a specific population in the NICU, if that makes sense.
I don't know if you have to be so specific, like, congenital heart disease or something like that. You can, I think the NICU is pretty specific when we're talking about transitional care. So I don't think you really have to drill down to one disease, because like we were saying, we're not just thinking about disease management as far as, this person has, what's another condition that they might be in the NICU for.
I mean, where I'm at, like they go home on
cystic fibrosis or, yeah.
Everything, respiratory,
yeah.
heart problems.
So I would think you would want to say, if it's end of life or not end of life. Because those could be two different things there.
Okay.
I just put a resource up. I know when we were, I was looking for the definitions. I found this transitioning newborns from NICU to home resource, and so I put it on that document, the link on the document on the agenda for you, so you can look through that and see. They say there's tools for hospitals to create a health coach program, tools for health coaches, information packets for family, and clinical materials to share with primary care providers.
Okay.
So maybe just even focusing on what information, what education are you going to give the person? And we know that when people are stressed out or if they're anxious or tired or being discharged from the hospital, that they don't really retain a lot of that information. So, it is good to give written information as well.
Yeah. I mean, that's what I'm hoping for, but I just feel like in our NICU, they're all so different at CHLA. Like at the NICU I'm at now, like that's like, I feel like cake where they're all kind of the same. They're all eating and growing, and then they just like go home, have to follow up and that. So over there, I think that's why I'm struggling, because I feel like what I give to one patient and mainline stream for a patient discharge isn't going to apply to the next NICU patient that leaves. So I think that's why I'm struggling at this NICU versus the one I'm working at right now. It's pretty obvious.
Right.
So
Yeah, and it's tough. You're not just dealing with the patient, you're dealing with the family.
yeah, so and
Right.
that's what I have to tailor it to is their needs. So I think
Right.
that's one thing too with these models. Obviously, I made comments that they're all based on geriatric populations, which is like very large population of healthcare. But NICU is a growing population too because they're saving these babies so early on, and now they're having all of these problems later on that they are going to be followed up for years.
Yeah. I have a friend who has a daughter with cystic fibrosis, and I was thinking of asking her to come in and talk about her encounters with the healthcare system. So I'll let you know when she can come in. She said Mondays were good for her, but just, you know, when she does come in and start talking, I just think we all need to be sensitive that this is her kid we're talking about. You know, if we're talking about patients back and forth, you know, it's not as personal. So just be a little sensitive. So I think I'll try and get that maybe the following time we meet. And I'll let you know. I'll put an announcement up, and maybe you guys can get some questions for her. Do you think that might be helpful, just to see the other side of the bed?
Yeah, maybe. I mean, I think it's always helpful to talk to people who have to deal with it firsthand, because as an outsider or administrator, you're not the one that has to technically deal with it firsthand. So sometimes you miss little things that make a big difference. So I always try to take the person who's dealing with it and see their perspective, because sometimes that solves the puzzle that you've been like missing. So.
Right. That's why I love, you know, motivational interviewing too, because you're talking to the person and finding out what's most important to them. Because people are only going to do, you know, things that are important to them. If they don't see the meaning in something, then they're not going to do it.
Yeah, then there goes all that work. So.
Yeah, that's how I am. All right. Well, thanks for sharing that, Erica. I mean, Elizabeth. Okay, Erica, you're up. Just tell us a little bit about your clinical experience and your preceptor.
So at the beginning, I have a little bit trouble of finding the population for this project because my preceptor is oversee outpatient. It's ambulatory settings. So it's because she's oversee all the primary care physician at family medicine, pediatric, OBGYN. So it's really hard for me to see the transitional complicated patient, like doing the hospital, transfer to the home. So then the only thing I can think of is because the preventive care services are so important to meet the triple N, which is promote a healthy population, reduce health costs, and what's the third one?
Patient experience is one, right? To improve patient experiences
and reduce the healthcare costs and improve the health condition. So I was thinking the preventive care probably will be something that I'm going to focus on, and which is also because I'm working for Kaiser. Kaiser is very big on preventive care. And even though we have very good technology to identify all the care gaps, however, the goal is not met. For example, like colorectal screening, the goal is 60%. A lot of the time, the provider might be, or the nurses might just meet like 20%. But the goal is like 60. So there's so many different kind of preventive care screenings, like pap smear, mammogram. So I probably going to focus on preventive care for this project. And
so when you're thinking about though people in transitions from one healthcare setting to another, how do you see preventive care helping the transitions? Because that's really what, you know, that the aim of the course is to think about care coordination and transitions.
So transitional care, I was thinking, well, I don't know if I go into the right direction, because I'm thinking about preventive care can prevent the chronic disease progress and getting worse, that can prevent admission that's what I was thinking. But from traditional care, from the outpatient setting, what I observed from the clinic is there's few ways. One is patient going home just after their primary care physical checkup, or it could be the patient need a transfer to the emergency room or going down to urgent care because sometimes I found out their physician maybe only work 4 hours or 8 hours, and then the patient need an antibiotic IV infusion. So that sometimes they'll transfer patient down to urgent care for continuum of care, or a patient's condition the acuity is too high, it's not able to handle an urgent care, they will call 911. And what I observed is sometimes when the nurses are family medicine, because they don't see a lot of sick patients, so a lot of time when they endorse the patient down to urgent care, a lot of time they didn't give out a very good aspire to the next nurse. So that's what my experience is, what my observation.
Yeah, maybe. It sounds like what you were just talking about is a little bit more like transitional care than what you were talking about before with the preventative care. I'm not sure how, like if you, I don't know, Sarah or Elizabeth, do you guys have any input on how this all might work?
I think if you focused on some sort of a tool to get your patient, like you were just saying something about, you're transitioning a patient from urgent care to ER, or you're transitioning a patient for care continuity, the acuity is too high. If you had some sort of tool to kind of help facilitate that, you were just saying something about the SFARs are pretty bad. We have a nursing home attached to our hospital, and it houses 100 people, and we spent time educating their predominantly LVN, MA, and CNAs, and a tool basically when we receive the patient back into the ER, what we want, just the bare minimum, and it's definitely helped the transition from the nursing home. At least it lets the staff know what our expectation and how to treat the patient best. Is that something sort of like what you're thinking?
I think that's a good idea to create a sport. I don't know. I just feel like because it's an outpatient setting, it's so hard to see the transitional care through what I am, my clinical side.
So are you in a primary care? Or is it more urgent care?
It's a primary care, but the difficulty is I have been with my preceptor. It's been I went with her 2 days. What I observed her is she barely touched any patient care. She's doing doing a lot of email, doing investigation, budget, hiring. And the only information I gather is just I ask her a question and she answer. So she don't do any patient care at all.
Well, that's okay, because this clinical was really set up for HAL students to work more with systems than to work with direct patient care. So, I think with like Sarah and Elizabeth might be talking, or Sarah was saying, she went to meetings with other people where they talked about, things like improving the triple aim. And maybe I can have a word with your preceptor and give her an idea more about what this is about. Because I know she did say, well, why don't you work on workplace safety? And I was like, no. So I'll get in touch with her as well, if that would help, so she can understand the course a little bit better.
Okay.
How are patients referred to I'm kind of unfamiliar with Kaiser. I know it's definitely a completely different setup than what I'm used to, but is there somebody who's directly making an appointment for that patient to your outpatient? I mean, is that something that's maybe something that you could work on where
Mm.
there's like a smoother transition from wherever they came from to having the appointment with the clinic where you're at or the outpatient?
I know there's a couple ways to make appointment for like the physical checkup. The patient will call the Kaiser because Kaiser is the organization is so big, so they have a special phone number for all the members to call, and they will talk to this representative to schedule their appointments. And sometimes take my urgent care as an example, like if we always address presentative care. So if I see is there any care gap, or the patient present to urgent care for, let's say, finger fracture, and then I found out their blood pressure is super high. The workflow is I suppose make them appointment for the nurse visit, and then if the nurse visit appear the blood pressure is still high, then we refer to primary care physician to book appointment. So it could be the nurse book appointment, or could be the receptionist, or it could be the call center booking appointment. Yeah.
One thing that you might want to look at is how Kaiser tracks patient using the EHR.
Mm-hmm.
That's a really big part of transitional care, and there's a lot written about using the EHR to flag when people haven't come back, to send automated messages and things like that. So maybe that's somewhere where you can focus on it. Kaiser uses Epic.
Yes.
Is that right?
Yes.
So yeah, they have a lot of great tools in Epic that help to improve transitions in care. So you might want to ask your preceptor, who can I talk to about how the EHR works here.
I see.
And maybe there's at some point, I think it might be too late now, but you might say like, oh, this isn't the best preceptor for me. If you switched in the next couple of weeks, that would be okay. But I'll talk to you a little bit more offline about that and with your preceptor too.
Okay.
I have just a thought for that. I don't know. I mean, it's kind of like transitional care, but it's waiting for that next, I guess, patient visit type of thing, where if in the system, like you were talking about the exams, like any type of exams that they have that's preventive care, is maybe creating like some type of tool or system that could be placed in Epic where it knows when it needs to be due, like when their screening is due. So when they have these follow-up appointments from provider to urgent care, they can constantly remind them that these appointments need to be made. That's the only thing I could think of in regards to like preventive care, but transitioning from each entity that they're seeking, whether it's urgent care, ED, that it's something in the system that they would be able to modify to have all of these screenings listed and have them checked off if they've done them or when they're due.
Actually, you brought a very important message. Yeah. Kaiser, because the EHR is the technology is so strong that we do require every single nurses, every encounter, they're supposed to click on proactive care, and that actually filter out every single care gaps that need to address. So we do have that tool, and because I also worked in an ED before, so also at Kaiser, but the outpatient setting, it's every encounter the nurse is supposed to address the proactive care, the preventive care, but the inpatient nurses does not require to address them. But then the tool was there. It is available already.
Okay. Well, that was just a thought. I don't know.
Yeah, that was a good point, actually.
Okay.
Okay, well, I think we can keep working and on that and see if we can get you kind of nailed down to one focus area, so you don't feel kind of like all dispersed with your ideas. Okay, I don't think I had anything else. Do you guys have anything? I really want to keep these to only an hour. I know we were supposed to meet an hour each week, and I thought, well, we'll do 2 hours every other week, but I think an hour's enough.
Professor, do you have like 5 or 10 minutes after the meeting with me, real quick?
Sure. Mm-hmm. Yep.
My question is, so obviously I said, there's a lot of buckets that I can dip my hand in at this point. So when would you suggest that I should have this, whatever kind of area I'm going to focus on, nailed down by? Because I feel like, because I only had my one clinical last week, so it was kind of going over everything and seeing exactly like what I need and what I'm looking for, and then kind of talking to different people to kind of start to, I guess, figure it out, like what kind of angle I wanted to take on it. And now it's just population wise that I'm trying to figure out. So what, I guess, by what time frame would you suggest based off like the dates of the project?
So February 18th is the approval of the care management assessment topic. So that's when you should probably have it nailed down by.
Okay. All right, cool.
And before then, we have, we talk about elements of care management that are used at your facility in week 5. Week 6, so we talk about aging in place. So those are kind of some, just some more didactic and theory content before we get on to really doing more assessments and doing the SWOT. So by February 18th is a good time to, have landed on something.
Okay, cool. Thank you.
Mm-hmm. Any other questions? That was a good one. Put that in here. By February 18th. Okay. Approval the 2 Ps. Have you used that Grammarly that I told you about?
I have for,
I
I
love
believe, the theology class. There was a couple of them that I used it for because so much of my content was information from other sources, and I was kind of nervous because I kept reading things and thinking, well, did I say that? Did I think that? Did I read that somewhere? And so I love it. It's a great service. Yeah.
Good.
Yeah, it's a good one.
I do have it too because English is my second language, so I rely on it a lot.
It saves me all the time when I'm like putting comments in your discussion post. Every other sentence there's a little red line under it because I try to type so fast that I miss some letters sometimes. Okay, any other questions? All right, well, keep up the good work. Let me know if anything doesn't make sense within the Canvas course or any questions about anything at all. And I will stay on the line for Erica, but Sarah and Elizabeth, we will talk to you later. Thanks for coming. Bye. I'm going to stop sharing my screen and then I'll stop the recording.